Now let's discuss the management of bladder cancer. If a patient present to you an OPD with hematuria, how to proceed? So first we are taking a detailed history, then we going to perform a detailed urological examination. Although it will not reveal you non-muscle invasive bladder cancer, but can help you in identification of the muscle invasive tumor. Then we are advising the patient the baseline investigation, which include CBC, and as the patient is having hematuria, so we will be looking for HP. Then we will advise the patient serum creat that will be helpful to give us a baseline creatinine level, and then we will see the urine DR and CS, and to exclude any infection and to look for any RBC present in the urine DR. So it's important. Then we will be coming for imaging. In imaging, our first line investigation and the screening investigation, that is ultrasound. Ultrasound formats the characterization of renal mass, the hydronephrosis, and the visualization of the intraluminal mass in the bladder. Right, so it's important to perform ultrasound in initial investigation, and we'll tell you like this. Now, what's the important of CT scan or imaging? Now, CT scan can be performed in selected cases, like in ultrasound that have shown you that the tumor located in the trigone, or there are multiple tumor, or there is a high risk tumor. So you can go for CT scan. Otherwise, if there is a small tumor and very small growth, so there is no need to go CT scan before going to other investigation, because you know that 80% of the tumor are non-muscle invasive, so there is no need. If the tumor on ultrasound is a bulky multiple involving trigone, then you can go for CT. Now, what's other investigation we can perform for this patient? There is another modality which is called multiparametric MRI, but it's accurately can differentiate between the muscle invasive and non-muscle invasive, but still it's not in clinical practice, and it also having one of the pirate system which is called VI-RADS. VI-RADS mean Vesicle Imaging Reporting and Data System. So it's not in clinical practice. What else we can do? We can go for urine cytology, but urine cytology can tell us is a very sensitive for high grade tumor, means 84% sensitive for high grade, but 16% sensitive for the low grade tumor. And the positive wired urine cytology can indicate urothelial carcinoma anywhere in the urinary tract, but a negative cytology doesn't means and doesn't exclude the presence of the bladder tumor, and it can be done on 25 ml of the urine. So it should be discussed in your investigation. But there is a one classification system for this urine cytology which is called the Paris system, and that's actually having 5 things. Number first, it's saying if the patient is having no diagnosis, means no adequate diagnosis is possible, that is called no diagnosis. The second, if urine cytology is negative for urothelial cells, means your cytology is negative, showing no urothelial cell, that is called negative. And the third, when your urine cytology is showing atypical urothelial cell, that is called atypia. And the fourth is when there is a high number of suspicious urothelial cell present, that is called suspicious. And when there are high number of urothelial cell, we call it malignant. So that was all about urine cytology. What else you can go for? Sir, we can also use urinary molecular urinary जो molecular marker है, we can also use that, but that's still not in clinical practice. And there are various type of urinary molecular marker, and that having a very good specificity, although with very low sensitivity, and it's include NMP 20 22, nuclear matrix protein 22, and the other is bladder tumor antigen, and the other is telomerase. So you can also use these with urine cytology. These are urinary molecular marking. So these investigation, and then after that all, if a patient, if ultrasound showing no growth but the patient is having hematuria, then we can go for flexible cystoscopy. And in flexible cystoscopy, you can identify if there is any small growth or small tumor, you can identify that. And second, if a patient is having positive cytology but the on scope you found that there is no tumor, then you can go for a random biopsy, but we will discuss in detail. Now, if a patient is having positive cytology and the patient is having hematuria, but on flexible cystoscopy there is no tumor, so we have other modality for tumor visualization, and that's also important for the identification of the tumor. So let's discuss that new things, and that's the one which we are routinely using, that is called white light cystoscopy, but we can use blue light cystoscopy and narrowband imaging. Actually, this procedure is done in a condition when a patient having positive cytology but on routine white light cystoscopy there is no tumor. So blue light cystoscopy is actually done in these patients in which we are installing one of the photoactive agent into the bladder, and that's leading to the visualization of the blue light. And this blue light is having wavelength of 360 to 450, and we are injecting actually installing the photoactive agent, and that photoactive agent is called hexaamino levolonate, and this is the only approved by FDA. We install that into the bladder of the patient 1 hour before the procedure, and the mechanism of action of this blue light is that after installation into the bladder, it is absorbed by the urothelial cell all over the urinary bladder, and it enters the heme metabolism pathway where it is converted into porphyrin, and that porphyrin will be visualized on the blue light cystoscopy. So these photoactive porphyrin tend to accumulate in rapidly proliferating cell more than the normal cell, and when we use blue light cystoscopy, that will appear the tumor cell will appear red and the normal urothelium will appear blue. So this is the concept of blue light cystoscopy. But there is a problem with this blue light cystoscopy, that these can be absorbed by inflammatory cell. So inflammatory cell can also give you same impression. The other is the narrow band imaging. Narrow band imaging is actually consisting of a two light in two wavelength. One is a blue that is having a wavelength of 415, and the other is the green that is having wavelength of 540. And the blue is actually having a short wavelength, and that assists the mucosa vascularity, while the green band, which is having higher wavelength, that is 540, that penetrate deep and that assessing the submucosa vascularity. So this is the concept of narrowband and blue light cystoscopy. There is one another which is not yet used, and that is called SPICE using 4 different lights spectrum modality, and that is suggesting improving the diagnostic accuracy of the bladder growth, and it's still under investigation.